All right, well, good morning, everybody, and thank you for joining us today. So, on behalf of Screen and J and the Rutgers Cancer Institute of New Jersey, welcome to Community Cares and Project Echo. And thank you again for joining today's session. And we hope that the information shared today will help you serve your communities better. And so, just a few announcements before we begin the presentation. If you could please keep your microphones muted during the presentation. Enter all questions into the chat box. And as a reminder, we are recording today's webinar. As a quick disclaimer, the information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health problem or medical condition. And all logos, text, and images used in this presentation are the property of their respective copyright owners and are used here for educational purposes only. If you would like to use any portion of this presentation for non-personal educational use, please contact the meeting host or presenter for express permission. And then here is just today's agenda. So we're going to do the Project Echo Series overview. We'll do the introductions of today's presenters. We'll the presentation, the case study, and then we'll conclude with a question and answer forum. And you guys are already doing this, but if you could enter your name, your organization, and the area that you serve in the chat box so that we can get to know you as well. And so a little bit about Project Echo. So the Rutgers Cancer Institute became a Project Echo hub in 2021. And Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. And this is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. And if you would like more information on Project Echo, there is our website down on the bottom right-hand corner of the screen. And so now I will turn it over to our presenters.
Good morning, everybody. So we're very happy to be here. My name is Diane Lack. I'm actually the manager for women's imaging for St. Luke's University Health Network. I oversee about 10 of our diagnostic and screening women's imaging sites. And prior to that, I've had a vast experience in healthcare as a nurse navigator working in the emergency medicine field, and then transitioning over to nurse navigation in the women's imaging field. I have the pleasure of working with Metsa. I'll let her introduce herself here.
Thank you, Diane. Good morning, everyone. We are very excited to be here this morning. My name is Metsa Osmanzai. I've been a memo tech for about 5 years with St. Luke's, and prior to that, I have worked in the emergency room as an X-ray technician and also in the OR. So we are very excited to present for you guys.
So the topic we're going to take a look at for this team today is that cancer health literacy. So as we take a look into this topic, we can go to the next slide. There are 3 main objectives that I really wanted to work with Metsa to help to discuss today. The first one is taking a look at that definition of health literacy. How does that definition of health literacy play into that cancer health literacy? So the second topic would be understanding that importance of cancer health literacy and how that overflows into the cancer care realm. And then finally, evaluating what healthcare providers can do to improve the impact of healthcare literacy as a whole, what recommendations are out there and how that will look for everybody. So as we move on, the first 3 questions that we want to take a look at and really have an overall view of. The first one, they're all true and false. First one being health literacy only affects patients going through complex health issues. Number two, one way to effectively promote health literacy is through education with simplification of information to make it clear and concise. And then the third question, nurse navigation can be utilized to support patients that are working through complex health issues, assisting in improving overall health literacy. So if everyone would take the time to fill out their survey.
I would say let's give it another maybe minute and then we can move on.
Sounds good.
Okay, Diane, you're good to move on.
Thank you. So let's take a look at what is health literacy. So health literacy is the ability to find, understand, and use health information and services for oneself and others. So that's the definition that's put out there by the CDC on what exactly health literacy is. So when we take a look at that statement and really dissect it, it's what is the ability to find. So are those services available to somebody? Do they know exactly what they're looking for? And are they able to obtain those? The second concept in there is, are they able to understand? Does the patient have the ability to understand what is required of them, what those goals are, and what that information being provided to them is? And that third portion, using that health information and services. So are they able to use the health information that's out there? Are they able to use the services? Do they have the resources available to them to get those? I think a lot about that when I think through the transition to electronic medical records and electronic resources. We're providing these to give hands-on access to our patients, but are all patients able to use that? Do we have resources set up to allow them to extend on that and be able to get if they are not able to access those different services? So it's been proven that lower health literacy rate is associated with poorer outcomes and the decreased use of services. So how do we improve that, and how do we get our patients to be able to access the care and able to understand to provide better outcomes for them? So when we move on and look at what are some of those barriers that patients may impact when they're taking a look at their healthcare and their journey that they're going on. So linguistic proficiency in English is a big one. In many areas of our country, our states, our areas, patients may not have the full understanding of terminology in English. So how do we better communicate with those patients, ensure their understanding of what we're communicating to them? Poor communications between patients and providers. You'll hear later on in this discussion about different ways that communication can be improved, but explaining to those patients in an improved communication way to make sure that they're understanding what the expectations are or the recommendations. A lot of times we find ourselves being tasked with timeframes in order to discuss with patients, timeframes in order to have conversations. So those discussions become brief and involve complex medical jargon that many patients don't understand. You look at written health information materials that use language that exceeds the reading level of the intended audience. Are the patients truly able to understand what's written? Next, you look at medications, and patients have difficulty in following those medications instructions. How do we ensure that patients are able to understand their medication regimen and how they're able to ensure the follow-up and compliance with that medication? Patient difficulty in communicating with their healthcare providers. Are we making that access for that patient a seamless process that they can communicate, whether it be by written, whether it be by telephone? Are we making sure that that patient has a way to communicate and get the feedback that is needed for them? If not, that patient's compliance is going to be very difficult. And then patient difficulty in attaining health information. So when you look at that, it goes back to, are they able to get that health information that's needed? So then we look at cancer health literacy. So when you think through cancer health literacy, we'll talk a little bit here about what I did in the nurse navigation role, get into that a little bit more in the later in the discussion. But within our network, we utilize two types of nurse navigation. The first one is that nurse navigator who assists when patients are coming back for breast imaging through the time of their diagnosis. So when you think of that new diagnosis that a patient receives, you think through that patient has just had a moment where their world has been changed. It's a brief moment in time where they have this new and complex medical world since they're diagnosed. Those patients are now tasked with all of this other information. They're now tasked with a multidisciplinary collaboration, a group of physicians and nurses and ancillary team members who are all coming together to support them. But during that time, they now have also been focused on that increase in anxiety, that all those things coming together so quickly. Counseling outcomes. Are we spending the time with the patients in order to provide that counseling with them, to explain things in terms that they can understand? Are we taking the time to look that those patients a lot of times have no medical background? So they have no understanding of what to expect, what those next steps are, what is going to be happening. And they have an increased anxiety. So now they are faced with this new and complex world with all this anxiety about the unknown that they're up against. And they're hesitant about speaking up. So that hesitancy in speaking up with those questions causes increased anxiety. And that decreases the ability for that patient to participate in their own care. They have so much going on in this very short time, this new change in process for them, and they're being tasked with all of those things together. So I want to go on to the next slide and just go through one patient's journey with you. The patient you'll see on the screen is a 34-year-old male patient, an accountant by background, had 3 young children, a wife of 16 years, and presented himself to the emergency room with a GI bleed. Patient was quickly evaluated, placed in the ICU, received medical evaluation, CAT scans, X-rays, lab work. Came from a background of a very educated family. Sister was an attorney, another sister in healthcare. Parents were business owners. Next thing you know, he had a surgical intervention. They had to remove an area of concern from his colon. Shortly thereafter, the surgeon came out and discussed with the family and said, it looks like stage 3 adenocarcinoma. That was taken by the family with not a lot of understanding. What is adenocarcinoma? What does that mean? What are the next steps? Where do we go from here? Everything was placed into the physician as the person who was going to take those next steps. The physician was the navigator for the patient and the family. Patient had 6 months of chemo, was placed into a remission status, followed up with the CA-125s for an extended period of time. I think it was about a year. And after that year, the CA-125s became elevated and the patient had new metastases to the lungs and the liver. Patient was then went to a different institution for additional care, for more specialized care, and ended up passing away just 3 years after that second diagnosis. Now, I bring this journey up to you for the very reason of this is a personal journey to me because this is my brother. So as a nurse going through this journey, we were tasked with what does this mean and how does this relate? And when you look at it, the physician spoke to me as a colleague as opposed to a family member. They spoke to me as someone who is in the healthcare field who may have understood exactly what they were discussing. Unbeknownst to them, I was an ER nurse at the time. I knew very, very little about progression of cancer care, cancer treatments, and the way to progress from there. So for me, taking a look at this journey has transitioned my life into the way of how can we better serve our patients? How can we better educate our families? And how can we support that journey for each and every patient? Because a journey is each patient's journey. It is an individualized journey for them and the family. Education is always part of that, and walking them through that is very important. So when we move on in this presentation, I was able to look at the associations for the cancer centers. This Association of Cancer Centers provides us with a lot of this great information here on recommendations. How can we work and do better in order to promote this healthcare literacy for each of our patients that come through? So the first recommendation that the ACC has is to promote more effective communication between patients and providers. And how do we do that? We implement communication trainings for clinicians, utilizing different types of training programs, whether it be role playing, whether it be feedback. All of those information statuses provides the clinician a way to step back, take a look, and see how that communication is being provided and received. Providing clinician education regarding components of palliative and hospice care. In my family's personal journey, that hospice care wasn't provided until 5 days prior to his passing. So talking about those communications and removing that stigma of palliative and hospice care and providing it to patients that are in need provides not only that positive impact on that last portion of their life, but also on that family's care for them. The inclusion of family in communication processes. This is so important. As a patient is going through any kind of transitional diagnosis or even going to the physician's office, a lot of times they have so much on their plate that they are not hearing exactly what that provider is saying to them, what exactly those recommendations are. So including the family, whatever that looks like for that patient in that communication process allows for better absorption and information retention for those patients. Clear and concise information on complex health information. This takes it back to if you are speaking to a physician, a nurse, no matter what that educational background is, we always need to make that information clear and concise, no matter what, again, no matter what that educational background is. We want to make sure that that patient is clearly understanding what is said, that they have the comfort to ask questions and the ability to have open discussions. And then facilitating open discussion regarding cost utilizing health insurance literacy. So again, this focuses more on that health insurance literacy that's part of health literacy. So we want to open that discussion and allow for patients to understand also their healthcare plans and what their insurance is covering, utilizing a financial navigation, utilization of resources that are available out there. This open communication, as we've seen within the women's imaging field, when someone is aware that they can have additional screenings or support in getting their imaging completed, they're more readily available to comply with their preventative screenings, as opposed to those who are afraid to do so because of healthcare cost or issues related to insurance. Some other recommendations that we come across is counter misinformation in the public realm about cancer treatment. Education, education, education. So education in the community regarding cancer prevention, getting out for patients to understand what they can do to help prevent cancer within their community. So we take a look at this in the effects of, I'll always focus back on breast imaging. We get out into our community and we talk to patients about what their requirements are for them. What is the best practice for them in providing that breast care? Because we want to educate them on what they can do for themselves. And one thing that Metza is fantastic at doing is educating her patients that breast cancer has to start somewhere. So just because you don't have a family history does not mean that it won't happen to you. We also need to develop evidence-based information for patients, families, and communities. What can we provide out there to our patients, to our families, to the community, to make sure that they are understanding what information they need to know to better serve themselves, to share with their loved ones, and to share with their teams in the community. And utilization of social media for public information. So social media can be a friend or foe, and utilizing it in order to provide that fact-based community education is imperative to get that information out there to those that we love and those that are looking on social media. And engaging our community in conversations regarding health using clear and plain language. So utilizing those conversations when we're out in public to make it clear and basic so that people understand what those conversations entail for education for future healthcare. Now, the third recommendation is meeting that health literacy needs of diverse populations and promoting culturally competent communication. So diverse patient population oncology research and care, making sure that we're getting all those population based when we're doing any kind of research, when we're caring for our populations, making sure that it is based on the cultural dynamics of that patient. So it's ensuring within women's imaging that populations are cared for in the way that they choose to be cared for, that those cultures are being supported and that their needs are being met. We need to engage in support of health literacy in underrepresented communities. How do we take what we're doing into those underrepresented communities? How do we make sure that those patients are able to get to the screening sites, the diagnostic sites, the appointments that they need to get to? How, as a healthcare network or as a community, as a nation, do we get these patients to get the care that they need? And then patient-provider communication that meets that cultural and linguistic needs of the patient and the family. So ensuring that the patient and the provider are able to communicate in a way that there's understanding on both sides, because not only does the physician need to communicate what the recommendations are, the patient needs to be able to communicate, whether it be their cultural needs or whether it be their individualized care needs that they're requesting. They need to be able to communicate that appropriately to the provider that they're meeting with. And then finally, promoting health literacy within healthcare organizations. So how, as a team, do healthcare organizations promote that health literacy? So it's regularly assessing that patient literacy need to identify opportunities and to build that health literacy. Implementing patient navigation programs, training employees in best practices for communication and strategies used to address health literacy in patients and families, and providing policies to support patient self-management. So taking a look through those, the one that truly hits me as a nurse and a nurse navigator, you can go to the next slide, Gabby, is that of nurse navigation. So as Metz and I had mentioned, we work for St. Luke's University Health Network, which is a hospital network in Pennsylvania and New Jersey. And what we utilize is nurse navigation. So nurse navigation, we have a breast nurse navigator who works on our imaging side, and then we have a breast nurse navigator who works on our oncology side. The breast nurse navigator, as I briefly mentioned before, works as the communication staple when a patient is called back for additional imaging, when a patient has a new breast lump, breast pain, any kind of concern. That nurse navigator is that first point of contact for that patient. That nurse navigator gets some basic information from the patient to ensure that best imaging is ordered for that patient. They work as a collaborator between the multifaceted group with reaching out to the physician for any orders that may need to be obtained. They work to ensure that that patient's prior imaging, whether it be from the same network or another network, has been obtained for best comparison views. And then they work with the patient if a biopsy is needed. They work to support that patient through that biopsy completion, and then follow up that patient after the biopsy is completed. Once that diagnosis is returned, whether it be benign or malignant, that nurse navigator is the one to collaborate with the patient to talk about next steps. If next steps require additional appointments as far as malignancy and going in through a cancer care surgical oncologist, that nurse navigator will be the one to assist that patient in setting up the appointment, and then does a warm handoff with that breast nurse navigator in oncology care. That nurse navigator in oncology care then takes that patient, takes that case, and is the one to walk through that entire journey with that patient. So that breast nurse navigator will take that patient and will continue on through diagnosis, through the finality of any kind of remission, survivorship, or any other care that is needed through that entire patient's journey. So that breast nurse navigator is there to be the resource, be the support system, and to have all that communication and walk right next to that patient through that entirety of that journey. So additionally, with the navigation, we also have a financial navigator. These financial navigators work as advocacy specialists. They work with insurance company, grant specialists, and really work to ensure that financial needs is not an issue for patients coming in for any kind of oncology breast care. We also have equity specialists who work to ensure that those patients are taken care of and ensure that, again, financial needs are met for these patients and teams are worked out, again, so that financial needs do not come as a barrier to patients getting the care that they deserve. So when we look at the specifics of nurse navigation on the next slide, we look at 6 key components to that nurse navigator. That nurse navigator is a patient support. They are personalized support throughout that entire patient's journey from beginning to end. They work through survivorship planning, so they assist patients in survivorship plans, post-treatment appointments, lifestyle changes, what other needs those patients are going to need through post-survivorship. Coordination. Coordination's a big one. Making sure to coordinate those appointments, the tests, the consultations for seamless delivery of care. Education, diagnostic treatment, providing resources, empowering those patients to make the best informed decision for that patient at that time. Emotional support, addressing the fears, the concerns, and being able to provide coping strategies for the patient and the family throughout that entire journey. And then finally, advocacy, ensuring that that patient's voice is heard, making sure that the patient's needs are met and that that individualized care is being completed. So moving on to the goals of improved cancer care health literacy. So why is cancer health literacy so important? What are some of those goals? We want to be able to provide everyone access to accurate, actionable health information. We want to deliver that person-centered health information and services, so that individualized care. We want to support lifelong learning. How can each of these areas of different changes in our healthcare support us? It's in that continued learning in ways that we can support other people. And we want to be able to support those skills to promote good health. Education provides that, but supporting that good health and promoting that health is imperative. And improved patient decision-making. We want patients to be able to make the best decisions for themselves at the time that they are being presented with something new. And I'm going to turn over to Metsa to go through some literacy for individualized breast care.
Thank you, Diane. That was wonderful. So I have hands-on experience when our patients comes in and how they dealing with anxiety of it and educating them. And most of our technicians do such a great job. But how do we communicate with these patients? How do we make sure they're understanding and they absorbing the information we're giving to them as well? One of the things, implants. We have a lot of our patients that get implants or they have had implants post diagnosis of cancer, and they have it for reconstruction, and they're coming in, and one of the questions we always get is like, is my implant going to rupture if I do a mammogram? And so educating them, no, it is safe. We do mammograms on patients who do have implants. If they have a lumpectomy or they had an implant, it's still safe. We could do them. There's different positioning that is required that we do. There's different techniques and different protocols that we do for our implant patients. So we do educate our patients in that and just providing that information, and also really communicating in terms of what exactly am I going to do for you with implants. How much compression am I putting in? It does not damage the implants. And if they need to, we always have pamphlets and things like that we could always provide for them and give it to them as well, making sure that they have that information as well. Our mastectomy patients, educating them as well is important to do self-breast exam, even if you don't have, you did have a full mastectomy. There's a lot of cases where they're coming in and we still want you to do self-breast exam, especially like under armpit or in the axilla, because there are chances that, it could reoccur there. Also, educating them, if you did have a mastectomy and you do have implants, we do recommend them getting an MRI and, just to see the integrity of the implants and making sure that, there's no rupture or anything like that. So just because a patient does have a mastectomy, that doesn't mean you should not be doing your self-breast exams or, evaluating it with your doctor or oncologist, and what are the proper exam or proper imaging is required for it. So most of our technicians, and we're always available for our patients to call us, and they do call us and our nurses, and kind of educating them when they do have these questions. Is it safe for me to get a mammogram with implants? Is it safe for me to get in, mammograms done with patients who have mastectomies? We do ultrasounds for them. There are other modalities, even if we cannot do through mammogram for a mastectomy patient, for example, but we do have MRI and ultrasound and other modalities that we are able to still be able to, individually take care of that patient that needs to be. Family history of it. This is something that each one of we start with our screening. We do a family history in all of our patients, and educating. There's a lot of times you have patients that you're like, why are you asking me all these questions about my family history, or I don't want to answer it. So we do educate them, how much your family history could affect it. We do a therapeutic risk assessment, which we do provide this information to their physicians. So not only the patient will have this information, but the physician will also get it. If the patient does come based on the family history, where they're in that high risk category, we do recommend additional screening with that. They do qualify getting an MRI or, done, and or additionally like an ABIS, which is an ultrasound, automatic ultrasound guide. So this way, we're not only looking at that particular patient, giving them individual attention just for based on their family history of it, but we also monitoring that breast throughout the year with different modalities, making sure that that high risk patient is getting everything that they need as well. But most importantly, when we are doing this, as when the patient comes in as a screener, we go through all the family history. Did anybody have breast cancer, based on the recommendation from Breast Cancer Society and ACR. They do recommend a patient who has a mom who's been, had a breast cancer at age of 40. So then, they recommend the family member to start an earlier screening. So we would see a patient coming in at age of 30 or, to do their screening, but we want to also educate them. Why are you just getting it? Just because my doctor told me to go and get a screening, but all right, let's get into your family history. Is there a family history of it? And, educating them of that. Or they would come in, sometimes start their screening early because they had their great grand that had it or something like that, which, that risk level is lower. So educating them again, yes, you did have a family member that did have breast cancer, but in this scenario, it's probably best for you to wait until 40 because we don't want to radiate you 10 years earlier than you need to be. We do use radiation and, educating about that, our patients as well. We also do genetics, offer genetic testing throughout St. Luke's. We do have our information, every mammo room and our ultrasound room, we actually keep pamphlets there available. If a patient is interesting, we do offer it for them and they could get their genetic testing done. If, I see a family, patients coming in, they had 4, 5, 6 females in there who had breast cancer. And one of the questions I would always, that's one of actually, for us at St. Luke's, it's one of our hard questions, meaning if we do not answer this question, we cannot proceed with our imaging is, did anybody have genetic testing done? Knowing that they have a high risk. And then if they say no, we do provide them with more information if they are interested in it to get that genetic testing done. Most of the time patients are very willing and they're like, yes, I was always considering this. I would love to, know more about it. So just having that available, but we do, that's one of the, like I said, for us, how we implement that into our network is that we ask that question. It's one of the hard questions. We want to know if you had, you're a high risk and you had multiple females in your family who had breast cancer. We want to make sure if they are willing to, or did they have genetics done, we want to make sure that we are documenting that as well. And also transgender, this is one category of individuals that we are still learning and trying to do better at it. But just knowing that they, if they did had any hormones or they have taken hormones and they're have history of it, to providing them with screening mammograms, and also educating our technologists and how to proceed with a patient who is transgender and how to do their mammograms, especially if it was an individual who was transitioning from a male to becoming female. This is their first time coming in for a mammogram, just educating them and taking one step at a time. So we actually set the patient down and we go throughout their history, and then we actually go every step of the way. We explain to them what we do. We also actually set them down for the first one just because they never had it. We want to make sure that they are comfortable for the first position. So we have other options to do as well, but also just educating them. Why are you getting this? Why am I getting a mammogram? And understanding that how much hormones could affect your, your breast density and breast pathology and everything else that we have. So educating those patients is very important, and understanding the importance of it to why we are doing the mammogram images for them. We could go to the next one. So again, I'm just going to go over some of the case studies that we have had here and how at St. Luke's St. Louis Women's Imaging, we implement all of the resources that we have to communicate and educate with our patient. This was one of my cases. She was a 35-year-old female, baseline, and she had a lump in her breast, which has progressively had increase in the past 3 months. So this patient coming in, she's already has that, no medical background of the information that we're providing for her to what she's going to be getting, what is a mammogram, educating her, explaining to her what views I'm doing, how many pictures I'm taking, how would it feel. As we did the mammogram, we did a bilateral diagnostic mammogram for this patient, and on her right breast, there was multiple sites that we looked at, and they looked suspicious. We did a diagnostic ultrasound as well. The areas where they circle, those were all looked very suspicious. We biopsied all those sites. So here's a patient, baseline patient, 35 years old, coming in, not knowing what a mammogram is, and the anxiety of getting all this information and right away telling her, like, wait a minute, now there's actually 3-4 sites in your breast that look suspicious, which we need to do further imaging. We go on to doing a biopsy, and the biopsy actually came back positive for this 35-year-old patient, and it was invasive breast carcinoma. Here it is, her world is, upside down, and everything has changed for a 35-year-old who has never had a mammogram done before. How do we communicate with this patient, and how do we make sure that the information we're giving her, she's taking it in? All the anxiety of it. This patient was here for us, and I think it was a Tuesday, and by Saturday we had already scheduled her to have a foresight biopsy done. And by the time she came to us, she had found out that she was pregnant. So here she is, 35-year-old. She has never had a mammogram done. She's coming in for a lump that has been increasing in 3 months. We tell her there's something in there. There's actually 3-4 things in her breast that we need to do a biopsy. She comes in and she finds out she's pregnant. So there's 2 things going on in that individual's personal life, which we sometimes don't know what's going on. We just giving the information, not knowing there could be a lot of other stuff that also could be affecting in how they are absorbing all this information. I have a child that I need to go pick up right now, and I need for you to hurry up with this information, and they're not. So making sure that they actually understand and communicating. We always tell our patients, all of this information is on your chart. You have access to this information. Your physician will get a copy of it. By end of the day, your physician will have all this information as well. One of the things we do at St. Luke's is make sure that each one of our patients have a physician. And if they do not have it, we actually do get in an appointment, find a physician for them, get them an appointment going, because sometimes you would have patients who you do tell them, but they're not taking in the information. You're getting the anxieties there, and having that health illiteracy and not being able to absorb all this information. We will also want to make sure we, contact the physician. The physician has all this information. And the big role of our nurses is they also get in touch with the physician as well, and making sure that they have gotten the results as well, and they have follow up with that patient too. So again, this patient, her whole world has changed at this point. She finds out she's pregnant, and we giving her, and this is one of the biggest thing with our nurses navigation. Not only we have to make sure she is in touch with an oncologist and make sure we find her, and also an OBGYN who's going to be able to take care of her through her pregnancy as well, and providing her. So our nurses did a wonderful job in just taking care of this patient and every needs that she needed to have. In any way, give the resources that we had, and communicating with our physicians, making sure that her appointments were coordinated, making sure, and as technologists for us, explaining to her the importance of why we did this mammogram, and, doing the biopsy, and it's just so taking our time and explaining to her. She was actually one of my patients, and I did set her down for her, just for when she came back after her biopsy, just so I could explain to her and show her the images. That's one of the things that even helps patients to when they visually see it and they actually see what is going on in their breast or in their body too. It really helps with that communication of understanding, because sometimes we're not taking verbal communication, but we are able to take actual going and working and seeing visually communicating with it too. And one of the best thing it is, if a patient has very high anxiety and they're not taking all the information, we go and talk back to our radiologist and we tell them, hey, do you mind and actually going over the case and going over the images with this patient? And they are more than willing to. We actually go sit down in the reading room, and then the radiologist goes over these images with the patient, and they are able to see, visually as well. So then we not only verbally telling them, but visually they are able to see like this is what we're doing, and it really helps that gap, of health illiteracy as well. We can go to the next case. All right. This was one of my patients as well. She is actually 92 years old. History of previously she had breast cancer in her 70s. And this patient comes in at 92 years old to us. She feels a little lump in her breast, her left breast, and she's coming back. And I remember one of the things she said, I turned 80 and I was like, I'm good. I don't need to get mammograms anymore and I don't need to come in anymore. So there's no reason for me to get mammograms anymore. But, educating and communicating to our patients about self-breast exams. And even if you're a good 80-year-old and, you can walk, talk, and I usually tell you, you're driving yourself, why not? Why not come and get a mammogram? Just come. It's going to take 10 minutes of your day and, we just do a quick mammogram, but we still want to provide you with that screening as well. But in this particular patient, she already had that, education or that health background. She already knew the medical background of what breast cancer is. But there was still this gap in this, she came into us and she was not expecting this at all to reoccur at breast cancer after 30 years of not having it. And all of a sudden she comes in with a lump and we do a biopsy and hers came back as invasive mammary carcinoma as well. So you could see, even though this patient is already known and has had history of breast cancer, educating her or re-educating her, because in this time period where she is right now in her life, she was not understanding. She's like, I thought I had it was removed and it's done. And I'm not gonna, but no, between us, our technologists, our radiologists, and our nurses, we were actually able to really talk to this patient and making her understanding that, you still should be doing self-breast exam, communicating to her doctors and communicating to our oncologist and what the next step is. And so just because a patient comes in and they do have that medical background, but depending on what their life situation is at that moment, that scenario, we still want to make sure that we are providing, just as if this is the first time she is getting breast cancer, just educating her and, walking her through every step, what we're going to be doing and communicating with that patient really reduces that anxiety and helps her understand and cope with what's going on as well. Okay, you could go to the next slide. All right, I'm gonna give this back to Diane, but we're just gonna go ahead and answer some of these questions, and then if you guys have more questions, we'll go there.
Great. Thank you, Metsa. So again, we're going to do the post-health literacy questionnaire. So health literacy only affects patients going through complex health issue, true or false? One way to effectively promote health literacy through education with simplification of information to make it clear and concise. And that nurse navigation can be utilized to support patients that are working through complex health issues, assisting to improve overall health literacy.
I would say give it another minute. We're getting good response rate, about another 2 minutes. If you have to hop off at 11, please take a moment to do both the post test and the survey. We'd really appreciate it. I'm gonna go ahead and end the poll.
Thank you. So answering those true and false, health literacy only affects patients going through, that is false. Anybody going through anything, whether it be going to the dentist, the doctor, that health literacy can affect in any stretch of that healthcare realm. And ensuring that patients are properly communicated with is so very important that they're understanding. One way to effectively promote is through education and simplification. Absolutely, that is true. We want to simplify that information, make it clear and concise, utilize any language barriers, support systems that we have to ensure that patients are understanding of what's going on. And then third, about that nurse navigation, absolutely true. We can utilize that nurse navigation as one of the many ways in order to help work through complex health issues to overall improve that health literacy for patients. So thank you. Thank you. I wanted to just take a moment and thank everybody for listening in. I know our background is mainly in women's health, women's imaging. So I appreciate you letting us talk to you a little bit about not only health literacy, but how that does impact that women's imaging and breast care realm that we work in. So thank you, everybody. So any questions?
That was a wonderful presentation, Diane and Metza. It looks like you actually have a few questions in the chat, so I can just read them off and then if you guys like to respond. So there's a question from Sarah. It says, if a male is transitioning to a female, what is a protocol for mammograms? Are you doing screenings or would it be considered diagnostic?
In our health network, we are currently doing them as a diagnostic. This actually lets the radiologists to be able to look at those images while the patient is already here. And we give them the results and the verbal results while they are here. And then, we give a written results through their chart and send it to their doctor as well. The recommendation is still they do get in a screening, but the only difference is, it's the same positioning, same images that we do. The only difference is we want to keep that patient here, and if any additional imaging that we need, we want to take care of it that right away, as if the patient needs an ultrasound or anything like that. It all depends. The recommendation is that if they have used more than 5 years of hormone therapy and they they're in high risk, meaning they have family members in there that had breast cancer, thing like that, then we do want to do a yearly diagnostic mammogram.
You want to add anything to that, Diane?
No, I think Metza hit it all very well. Again, the transgender population is becoming a much more focused area for us. So as we grow and as we learn, we're going to continue to work through those best practices to ensure that those experiences are met for the patients, because we want to ensure that that experience continues to have them coming back so that they're able to be open and communicative about any changes that occur and that they feel very well supported in the realm of breast imaging.
Wonderful, thank you. There looks like there's another question from Val. Says, I have a family member who is elderly and she feels she doesn't need breast exams. She states they hurt anyway. What would you tell her about the necessity of continuing breast exams?
I usually start with the machines now are so much better and faster. Most of patients are in compression less than 30 seconds. But more importantly, we do have our facility, we have what we call a duetta, where it allows patients to decompress themselves. So we do use and communicate with that patient. We generally are technicians, and when I'm positioning a patient, we go very slowly, and then I do compression very slow at a time, and I communicate with that patient. Are you okay? Is that okay? Are you able to tolerate this as well? And communicating with that patient really helps them and also allows them to feel like they're in control of having their mammogram and talking to them. But if, like I said, if you are a elderly person and you have a good lifestyle where you are on your own, you're taking care of yourself, you're walking, talking, and your mammogram the most is going to take 30 minutes a facility will take to do your screening mammogram. out of the whole year, I said there's 365 days out of the year, you could give 30 minutes to yourself and go ahead and just get your screening done. You know, early detection is everything, whether you're young or old. Unfortunately, you know, breast cancer has no age limit, no gender limit. There's no age, so just get your screening done, but just communicating. A lot of times if patients do have concern, one of the options we give them to come and visit our facility if they're in that area and just come take a look at our machines and what we could do. They don't have to get their mammogram done that day, but we do have them come walk through and how we do it as well. And that usually really helps patients as well, just knowing and seeing it beforehand before they come in and start too.
Absolutely. And Metsa, you hit the nail on the head there. That early detection is key. If you are able to find a small area at the age of whatever it might be and be able to get that cared for, who knows what the implications of that are. So early detection is key based on your individualized, and we use that word a lot, that individualized care, because there's no person that's the same. There's no journey that's the same. There's no treatment or diagnostic regimen that's the same. So it's all patient dependent, all history dependent, all care dependent, and all based on the wishes of that patient.
And it looks like we have another question. So how do you communicate this if the guidelines end in the 70s?
That was my question. I typed maybe a little too fast to make it, so it's piggyback off of what Metsa was just talking about. How do you the guidelines that we have end in the 70s, but we're talking about 80 and 90-year-olds. So how do we communicate that? Because I know when I'm doing breast education, I'm talking about general guidelines. The seniors get very insulted when they see that they're within that cutoff. So I always tell them, this is a conversation, this is general, this is a conversation you have with your doctor. Doesn't mean that you stop getting your screening necessarily. So how would you communicate that?
Correct. Like Diane said before too, it is very individualized. It depending on it, what kind of quality of life do you have right now? My personal opinion will be like, we shouldn't be losing any woman to breast cancer because the technology that we have and being able to detect breast cancer in millimeters, which is early detection. We finding things so small that we do a small incision, be able to get rid of that cancer and have a really good quality of life. The statistics is that 90% of patients who have early detection, they have a normal life. Compare that to any other cancer, say pancreatic cancer or liver cancer, where your statistics are between that 40 to 60% lifestyle. Why would I not take that, option of just getting my screening done and, but also, even with that talent, it all depends on what kind of quality of life do you have. I mean, there are patients who come and wait in 2, 3 years, 5 years, and they could be early and not necessarily, elderly, but they're coming in and now you have metastatic breast cancer or any kind of cancer that becomes metastatic at that point. It is a painful way of, anybody going through that journey of every single part of your body, it hurts and painful. And we could prevent all of that, especially with breast cancer and what we could do nowadays and how much we have. All it takes is, like I said, 30 minutes out of the entire year, one day, you're going to come in and just get your breast imaging done. And we're looking for those early detection. We're finding, especially with 3D mammography, which is becoming more and more standardized, doing ABISs, having MRIs in most of the facility, which detects up to 90 to 96% of breast cancer, doing a contrast enhanced biopsy or contrast enhanced mammography, which really is something new and up and coming. But those patients that are unable to get an MRI, they're not able to, it has the same sensitivity as an MRI picking up breast cancer. So we have so much to offer now for our patients and the comfort of it as well. I have a lot of my older patients who come in and they do make those comments of, this is extreme. When I used to get this, was very extremely painful. And they're correct. Originally, when mammogram came in, we used to do films and a patient used to stay under compression for 4 minutes for a single image. And we used to develop that going into a dark room and see if we have it. So it used to take about an hour to get a mammogram. And the compression time was a lot longer. Now it is less than 30 seconds. And most of the imaging while we're doing it is 5 minutes tops, and you're done. I mean, it takes more longer for patients to get changed, and we do questioning. So 30 minutes in total, but the actual imaging part of it, it is not as bad. And also with the elder citizens, if they are like, we do provide transportation for them as well. So that's one of the key things with having those patients is like, how do I get there? We do call Lyft for our patients to get them in here. There's other resources that we could provide as well. And we do like, communicate with the nursing homes and things like that as well, making sure that those patients are here and we, doing their transportation. And before the patient is done, we have one of our schedulers up front or one of our registration girls will call and make sure that they have transportation to take them back as well.
I think it's something additional, Evelyn, is there's a lot of different guidelines out there. So it's really that conversation that goes between the facility and the patient, the provider. And again, what's best for that patient as far as those different guidelines and what they'd like to follow. So we always want to make sure, that communication with that physician and what's best for that patient at that time.
That's extremely informative. Thank you. I actually had a question myself too. And so I guess we're talking about, the age range in the 70s and so on, but I guess on the flip side, what about some of the younger patients? How do you communicate the importance of like self breast exams for people that aren't at the age yet to necessarily get mammograms? Only because I feel like every time I'm watching the news or reading an article, it's always about how cancer is on the rise in younger people. And a lot of the time they're either putting off their symptoms as stress or a diet or something like that. So, as we continue to see more and more cases, is there a way to encourage younger people to be, better advocates for themselves? Like if something is unusual, to bring it up with their doctor, because I feel like a lot of the time they feel maybe they're dismissed because they're so young and they put off their symptoms to maybe stress or anything like that. Is that something that you guys come across? Any younger patients maybe?
Absolutely. We are seeing more and younger patients coming in. One of the best ways is really community education as well. It's not just here, but educating our community about self breast exams. We do a lot of health fairs in our communities that we do take. Actually, we have breasts that are have lumps in them, and we actually take those to our health fairs where we allow the community to come in. What is a self breast exam? How do we do this? And kind of doing, and just as a woman, knowing the importance of our body and educating that as well. I have a daughter myself, and she's 19, and I educate her about the importance of it. Your body best. And if any time you feel like something is not right or nothing, something is, just go talk to your physician, reach out, do the importance of yourself breast exam once a month. You want to make sure that you're feeling what you're feeling. But yes, we do get patients here that are younger. As far as the screening is concerned, we have other protocols that we have put in place too. We do have them do ultrasound first, and that's something we could see that targeted area where they have their concern. We saw that because we do want to prevent the radiation, but also we have things that facilities that we could shield the patients as well. So if they are younger coming in and we still need to do a mammogram, not that it's required anymore, the guidelines for mammogram, we do not need to shield a patient with lead before getting a mammogram done. But we do have protocols in our facilities in place that we do take care of our younger patients that are coming in, starting with that, doing an MRI or doing a ultrasound first before coming to doing a mammogram.
Wonderful, thank you. I don't believe we have any other questions. So thank you again, Diane and Metsa, for a wonderful and very informative presentation. If there are any other questions, you can reach out to us on our Might Need Network resources page, and we can always reach back out to Diane or Metsa to see if we can have those questions answered. But thank you again to our presenters. So before we wrap up for today, I'm just going to go through a few announcements. So in our state, we have NJCED, or the New Jersey Cancer Education and Early Detection Program. And it's a program run by the New Jersey Department of Health in collaboration with local agencies and healthcare systems. The NJC program provides education and outreach within the community about different types of cancer. They provide free screenings to those that are unemployed, underinsured, uninsured, or face barriers to getting the cancer screenings that they need. And the NJC program currently provides screening for breast, prostate, cervical, and colorectal cancers. And the program is offered in all 21 counties throughout our state. And so you can either give them a call or even check out their website under their facility search to find one that's nearest to you. And so thank you again for attending today's session. We would greatly appreciate if you could use the link that's going to be dropped in the chat or even scan the QR code to let us know how we did. We greatly appreciate your feedback so that we know what we can work on in the future or even any topics that you would like to see. And then just as a reminder, our materials and resources from today's presentation will be on our Mighty Networks community. So you can actually click there to register, and the link will also be dropped in the chat. And if you could just give us about 2 weeks for finalization, we just like to make sure everything is in order before we do post. We do appreciate your patience as well. And lastly, please join us in June for high-risk navigation. That will be our next topic. If you are not already registered, you can also register with ScreenNJ. You will get the reminders. You can just add it easily to your Outlook calendars. And so we really appreciate your attendance today. We thank you, Diane and Meta, for a wonderful presentation and extremely informative and something that, is very important as we go forward. And so if anybody else has any other questions, feel free to reach out with us. But if not, enjoy the rest of your day. Thank you, everybody.
Thank you all.
Thank you. Yeah.